especially Dr. Christopher. Good morning. And good morning, my colleagues. I appreciate the opportunity given to me to say one or two things about this question. However, after the presentation, there is an entertainment of anybody with one or two comments, especially those that participated in the question. So I'll begin with answering straightforward the question, then some few slides that are important about the condition. So the question said, a 60-year-old man present with 3-month history of cough with whitish sputum production and difficulty in breathing. No fever. He has significant smoking history of about 20 packs a year. He is a construction worker and has significant exposure to dust and fumes at his work. On exam, he had bronchi and his FEV1 over FVC is 0.6. Chest X-ray did not show features of bronchiectasis and lung fibrosis. The questions that followed are, what is the most likely diagnosis? What is the pathophysiology of the disease? What maneuver will you do during spirometry? And what are the differential diagnoses? And how will you differentiate between his condition and the closest differential? And our last question said, what's known pharmacologic and pharmacologic ways will you manage this patient? Okay. Looking at the age of the patient, is 60 years old, presenting with history of 3 months history of cough, dyspnea, and also sputum production. However, the sputum is whitish and he has no fever. And the chest X-ray did not show any abnormality, especially chest X-ray did not show fibrosis or features of bronchitis. So with this information in mind, and again, the patient works with, he's an industrial, he works with one of the construction company, and that exposes him to dust and fumes. And so with this, I believe chronic obstructive pulmonary disease should be my most likely diagnosis. So the second question said about what is the pathophysiology of this disease? The pathophysiology of this disease is the interaction of several risk factors coming together to trigger an abnormal inflammatory response. And this is characterized by infiltration of the walls of the bronchi and bronchioles with inflammatory cells, leading to continuous and persistent airway inflammation and subsequently limitation of the airways. And again, because the inflammation is chronic and persistent, in conjunction with the risk factors like those noxious agents, there is a change of normal columnar epithelium of the airway to squamous epithelium, and subsequently scarring and thickening of the bronchial wall, leading to airway narrowing and airway obstruction. There is also other things like destruction of elastase, anti-elastase, to some extent even the surfactant by chronic noxious stimulus of like cigarette smoke. And again, there is associated with increased hypertrophy of the mucosal wall, leading to increase in the number of mucus secreting goblet cells, and this further compromise the airway. So this is just brief, and as we are advised, it's better to go straight forward to the key terms when we are mentioning pathophysiology. So what maneuver will you do during this spirometry? Initially I did not understand this question, so I contacted somebody in pulmonology and also somebody that one of our seniors that participated and passed these exams. So we arrived at, they are trying to tell us, because even in asthma, spirometry is also important and the features may not be different. However, if in asthma, they tend to improve. If you know their pre-bronchodilator FEV1, following administration of bronchodilator, they usually have more than 15% increase in their previous FEV1, pre-bronchodilator therapy. But in this case, if you give somebody that and you do spirometry, the FEV1 may not rise to more than 15 or 12% as some guidelines. And again, a post-bronchodilator FEV1 over FDC will show obstructive pattern. And in most cases, FEV1 is less than 80% in addition to this. And some other things that need to be considered during spirometry are to avoid, in acute exacerbation of COPD asthma, it's not usually advocated because it's an effort-dependent thing, and it may compromise further the respiratory distress seen in this patient. And again, it should be well calibrated. It should be matched with the age, sex, weight of the patient, because all those, they contribute to the overall value of spirometry. So looking at that, the next question said, name differential diagnosis. You can agree with me, chronic asthma should come top as the most likely diagnosis. Again, this patient is a construction worker, exposed to certain dust, smokes, and chemicals that predispose him to occupational lung disease. So it's also top in my list. And there's nothing that stops this 60-year-old from having heart failure. And again, despite that, the sputum is not, the quantity was not given and it is whitish, it could still be a bronchiectasis. So the other ones are all differentials. Bronchogenic carcinoma, yes, because of the significant history of smoking, the age of the patient is also a possibility here. So the list is not exhaustive. There are a lot of things to consider as a differential, but I believe this should be one of the common things that we should entertain. So, and again, the question did not just stop. He said, you can just say, you try to differentiate the commonest differentials you listed. So I took chronic asthma. As we know, asthma, most of the time, they're diagnosed in early childhood, and it has their own variation of symptoms, sometimes from day to day, and usually there was at night or early morning. And there may be family history, especially in extrinsic asthma, and they have a history of atopy. And again, their airway is usually reversible. These are at the level of history and some of the investigation. However, even the pathophysiology, the cells, they are infiltrated. They're usually lymphocytes, eosinophils, and mast cells, as against COPD that we see is more of macrophages and neutrophils. So again, for bronchiectasis, the age still could be the same. However, they produce large amounts of mucous sputum, and with varying colors. And again, there could be halitosis, and finger clubbing will be prominent because it's part of the suppurative lung disease and they cause clubbing. And also on auscultation, crackles could be had, especially in the affected areas, unlike in just stable COPD or COPD where rhonchi could be had. Clubbing is not a common thing in COPD. I used to remember one of my teachers that said clubbing, if not because never in medicine, you could have said finger clubbing is never seen in COPD. However, it's highly unlikely. If you see clubbing, you think of other things like maybe development of bronchogenic carcinoma or any other things related to that. So bronchogenic carcinoma, again, because is a malignancy, and we all know it has a lot of paraneoplastic manifestation, and again, it can metastasize too. So patient may present, apart from this respiratory symptoms, may present with variety of extrapulmonary, ranging from metastatic to various organs and to paraneoplastic, especially the skin, like dermatomyositis, acanthosis nigricans, and to mention a few. Again, but however, in this case, the age may be slightly higher. And again, they may have hoarseness of the voice due to so many reasons related to the tumor. And again, they may have syndrome of inappropriate ADH secretion, ACTH, and other things like that. So occupational lung disease, yes, this patient, he's a construction worker. He had significant exposure to dust and smoke and some other irritants and chemicals that could predispose him to that. Again, in that, they usually have effort dyspnea and pleuritic chest pain, especially when they're at the workplace. And some of those symptoms, they are relieved when they leave their area. And usually in the weekends, they tend to do better. And the chest X-ray may have variety of features, unlike in COPD, where like in the index patient is normal, or at most he may have features of hyperinflation. But again, for this occupational, they can have fibrosis, pleural thickening, effusion, and other things. And in some of them, like silicosis and asbestosis, they may present with restrictive pattern. However, sometimes mixed pattern is seen. As against COPD, there is predominantly obstructive pattern. So the non-pharmacological and pharmacological treatment, starting with the non-pharmacological, there are a lot of things in the non-pharmacological, especially patient education is very important, not only in COPD, in all the disease. So patient need to know that this disease is a chronic thing and you need to align with, avoid risk factors. You also need to take his medication. He need to be taught how to use an inhalers, and you also need to know that the treatment is not for cure. It's just to relieve the symptoms and to reduce the progression of the disease. So smoking is very important, if not the most important risk factor. Patient should be well counseled about if it's like my index patient here that smokes cigarette. So one need to counsel him adequately, following the protocols of smoking counseling sedation. Then for any visit of a patient with COPD, you have to revisit the use of inhaler technique because they tend to get better by the way. Pulmonary rehabilitation is also part of the component, especially if they are at stage 4 of the disease. However, for this patient, we cannot hazard a guess because we don't have his predicted FEV1. Vaccination is very, very important in any patient that have COPD. It is known to, is one of the factors that is known to reduce the progression of the disease. So because chest infection by H influenza, pneumococcal organisms, they also contribute a lot in worsening and exacerbating their symptoms. So they advocated they should give that. Other things that need to be done as non-pharmacological exercise, we have to improve their exercise tolerance so that to some extent they can live freely. And nutrition is very important. It's one of the areas that is gaining momentum in COPD. There are a lot of things recently about nutrition in them. It's very important to counsel them about a healthy diet. And again, oxygen therapy, like especially the long-term therapy, is considered under non-pharmacological. Patient need to be evaluated if he qualifies for long-term oxygen therapy and be placed on that because it has shown to have some benefits. So these are some of the non-pharmacological. As I said, the list is not exhaustive again. So for pharmacological treatment, please pardon me here not to discuss this unless during my discussion of the topic. However, the pharmacological treatment depends on the stage of the disease and whether there are exacerbation or not. For this index patient, we don't actually know the stage, but I believe it's just chronic pulmonary chronic obstructive pulmonary disease, not in exacerbation, being that the sputum is whitish, there is no fever, and the symptoms are there for 3 months. I believe if it were exacerbation, he will have looked for treatment, and the symptom may not be there looking for him for 3 months. However, we have pulmonologists and senior colleagues that may add more light to that. So briefly, I have some few slides. And looking at the time, I have to be a bit, I may skip some of them, but they will add more to the topic. So chronic obstructive pulmonary disease, previously called chronic obstructive lung disease or chronic obstructive airway disease, is one of the, is a disease state that is characterized by airflow limitation that is not fully reversible as against asthma that is almost reversible. And it's characterized by airflow limitation that is usually progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. As recent as 2023, Gold defined COPD as heterogeneous lung condition characterized by chronic respiratory symptoms, dyspnea, cough, sputum production, exacerbation, due to abnormalities of the airways, especially the bronchus and bronchioles, causing their inflammation, or alveoli, as in the case of emphysema, that cause persistent and often progressive airflow limitation. That was the recent definition by Gold in 2023. COPD, as we know, is one of the diseases that is associated with so many other diseases like hypertension, like diabetes, and even are linking it with hyperlipidemia. And that's why some of the pulmonologists believe it should be considered as pulmonary component of metabolic syndrome. It's also associated with the ischemic heart disease and other chronic diseases. And one of the linkage is they are all chronic disease and they are associated with chronic inflammatory response. Is the fourth leading cause of death in USA and some parts of the world. And this is behind cancer, heart cancer, and cerebrovascular disease. And this prediction came more than 20 years ago that likely by 2020, this disease, and it's one of the diseases that pulmonology felt is not, the attention was not given much, and we don't look for them much. It has varying prevalence, uh, notably up 10 to 20%. However, some recent studies in Nigeria advocated a wide range of prevalences. I think the one I came across around is it 5 to 15 to 20, something of that. And WHO estimated 3 million deaths worldwide from COPD, and about 280 million people may be affected. In 1990, this was one of the predictions that COPD was 12 as the burden of the disease, but it was predicted six at that time. Sorry, as I said, it's comorbidities. So these are the risk factors, as we said, of COPD. You can see cigarette smoking at top. Is an interplay actually of the genetic, infectious, and luxurious age and socio-economic status. As we said, nutrition is very important. Malnutrition is also linked to that. And however, smoking is not the only risk factor for COPD. This is because there are several studies that back that, in that people that have significant past year history of cigarette smoking, in some studies, only 20% of them came down with COPD. This is one of these to emphasize the importance of genetic susceptibility to the disease, because almost a large number of people with past year cigarette smoking, they were studied and only 20% of them developed COPD. So this is to buttress the effect of genetic predisposition to this disease. So this is the pathogenesis. As we said, is an interplay of several risk factors ranging from noxious agent, genetic factors, respiratory infection, others like malnutrition. So coming together, stimulating a form of abnormal and persistent inflammatory responses affecting the small airways and the parenchyma of the lung. In small airways, they cause airflow inflammation and they interfere with the normal remodeling. And for parenchyma, they cause some destruction of the alveoli and elastic recoil, especially if they affect the normal balance of elastase and anti-elastase, as well as surfactant to some extent. So in overall, they lead to airflow limitations. So what causes this airflow limitation? Some of the factors are reversible, some of them are non-reversible. For the non-reversible, fibrosis and narrowing of the airways, loss of elastic recoil due to alveolar disruption, disruption of the alveolar support. This is achieved by usually surfactant. So these are usually non-reversible. For the reversible ones, inflammatory responses actually, their effect can be reversed. Smooth muscle contraction and airway hyperinflation. So these are the cells involved in pathogenesis of, unlike in asthma, we can see the top here, macrophages and neutrophils and CD8 lymphocyte. In asthma, as we said, is eosinophils, mast cells, and CD4. And we can see even the mediators differs. The top here, we have leukotriene B4, unlike in asthma is leukotriene B4, and some other proteases and other cells. So this is just a table to, in addition to clinical features that we mentioned during differentiation of chronic asthma with COPD. We can see the cells, as I mentioned, mediators again, and the effect usually all airways will be involved in asthma. However, in COPD, peripheral airways are first affected, and the response to steroid is remarkably marked in asthma, unlike in COPD where bronchodilator therapy is made. So for us to diagnose COPD, we need an interplay of symptoms and some exposures and the values from this spirometry. Like my index patient has cough, sputum production, and dyspnea of 3 months. And again, he has significant PACTA of 20 PACTA, and the occupation, he is a construction worker with chronic exposure to dust and smokes. So again, his parametric value is showing obstructive pattern. So this also to buttress that this patient actually have COPD. So what are the considerations in performing spirometry? Spirometry measurement are evaluated by comparison of the results with appropriate reference values based on the age, height, sex, and race. And we have to know that in a normal population, there is a decline in FEV1 when we attain 30 years or 40 in some recommendation. However, in COPD, they have exaggerated decline in that after achieving those years. And the presence of post-bronchodilator FEV1 of less than 80% predicted together with FEV1 FVC of less than 70% confirms the presence of airflow limitation that is not fully reversible. And in patients, sometimes patients may have predicted FEV1 of more than 80%, but again, show obstructive pattern. Still, we cannot say he doesn't have COPD, but likely he's at zero stage. But these are the kind of patient that requires monitoring. Subsequently, they are on their way to develop COPD. Spirometry should be performed after admission of an adequate dose of short-acting inhaled bronchodilator to minimize the variability. And whenever we have post-bronchodilator FEV1 of less than 0.70, it confirms the presence of airflow limitation. This is gold assessment of the severity. Whenever you have a patient with COPD, it's better to know the stage he is, because that has an implication to the treatment you are going to give him, and either some other management plan. So for mild disease, if you see all of them, they have obstructive pattern of FEV1 over FBC. But again, the predicted FEV1, it makes the difference. So for those that have more than 80%, they are stage 1. For those that have between 50 to less than 80%, they are moderate. For those with less than 50 to from 30 to less than 50%, they are severe. And for those with less than 30, they are very severe. This is the objective of treatment of COPD. You want to prevent the disease progression, relieve symptoms, improve exercise tolerance, improve health status, and prevent and treat exacerbation, prevent and treat complications, reduce mortality, and minimize the side effects from the treatment. So patients must be counseled about these goals, objectives, and none of the objectives said the aim is to cure. So patient must have an idea of that. Smoking is very important in COPD management. We cannot talk of COPD without addressing smoking. Like our index patient have a significant pact here of smoking. So we should follow the normal protocols of smoking cessation, those 5 E's. And other things could be nicotine replacement, bupropion, and varenicline. While we are emphasizing on COPD cessation, is one of the factors that modify the progression of disease, the arrest progression of the COPD if addressed well, and they have mortality benefit. So how do we, these are the goals of all management, irrespective of the stage of the COPD. We want to avoid risk factors, we want to address smoking cessation, we want to reduce indoors pollution, like my index patient with the construction worker. We may need to organize where he has lesser risks of exposure to those things. And vaccination is also very important. So vaccination should be discussed for this kind of patient. So the treatment usually as against asthma is bronchodilator therapy. Unlike asthma, steroids are top on the list. So we can use beta-2 agonists or anticholinergic, as they are known to be bronchodilators, and they are grouped into short-acting and long-acting. Short-acting, usually they are relievers. They quickly relieve symptoms, while the long-acting, they are for prevention. So then we should know that long-acting inhaled corticosteroid reduce exacerbation and related hospitalization and improve symptoms and health status. However, combination of the two classes, meaning either anticholinergic or combination of the two may lead to improve in efficacy and decrease the side effects. So for inhaled corticosteroids, they are shown to have improving symptoms, lung function, and quality of life, and they co-reduce FEV1 to less than 60% predicted. And for the inhaled, again, patients should know that they have increased rate of pneumonia, and the clinician should be aware of that. Meaning, we should look for that in a patient in a long-term inhaled corticosteroid therapy. So, as we said, Staging of patient is very important. And one of the important of that is to plan for his care and to know what to do at various stage. So for stage 0 that we mentioned that they have predicted FEV1 of more than 80%, but they show an obstructive pattern. And most of them, they just have some mild symptoms of COPD and they don't have spirometric abnormalities. So behavioral and modification monitoring is advocated. We need to address their risk factors. Addressing the risk factor will go away in preventing them from progression to some extent. Stage 1, as we highlighted by the GOLD criteria, these are the kind of patients that will do well on, can be started on short-acting bronchodilator therapy, meaning they need more of preventers if they took care of other risk factors. And for the stage 2, apart from the preventers, so they also need to be placed on one or more long-term bronchodilators. So they need some of, apart from relievers, they also need preventers. And we can think of considering commencing rehabilitation. It's a particular program for patients with COPD. Then for stage 3, again, apart from short-acting bronchodilator, one or more long-term bronchodilators, we can introduce inhaled steroids if they have repeated exacerbation. Again, pulmonary rehabilitation will go away in helping them. For stage 4, which is very severe, these are the kind of patients that, apart from doing the highlighted above, in most cases, they must have developed complications like pulmonary hypertension, copulmonal, polycythemia, and other complications seen in this kind of patients. So we should aim at treating those complications. And again, they must be under pulmonary rehabilitation therapy. And these are the kind of patients that when we assess them for long-term oxygen therapy, we find out they have one or two indications for that. And they could benefit from lung reduction therapy, which also is shown to have some benefit. So this is an indication for the long-term oxygen therapy. A stable patient with a normal partial pressure of oxygen, but there is presence of, stable non-smoker with this normal partial pressure of oxygen, but having pulmonary hypertension, copulmonal, nocturnal hypoxemia, they qualify for long-term oxygen therapy, and sometimes we consider terminally ill patient. And even for patients that have partial pressure of oxygen greater than this, so if partial pressure oxygen is maintained for more than 8.0 by giving oxygen for 15 hours a day, 3-year survival is improved by 50%. So these are my references. Thank you for listening. Comment are entertained for senior colleagues, and for our teachers, and as well for our latest fellows that participated in this exam. Thank you very much.
Okay, thank you, Dr. Yahaya, for your presentation. Now the floor is open for questions and comments. There was a question in the chat box, but I think I logged up briefly, so I can't read it anymore, but I don't know if the person can repost it or ask the question verbally. Thank you. Dr. Kele, you can ask your question.
Good morning, my teachers and colleagues. Thank you so much, Dr. Yahaya, for the excellent presentation. That was a very detailed and lucid presentation. Okay, I just wanted to make some comments. Okay, on one of the slides you posted, I saw 2014, like for the 2014 guideline. I just want to inform us that there's a 2024 guideline for a GOLD guideline for COPD management. So, okay, and then also on when you were talking about the treatment, you mentioned short-acting bronchodilators used as needed. So I just want to make a correction. We don't usually use short-acting bronchodilators as maintenance therapy, even for as needed. We use the long-acting. You know, most times the short-acting bronchodilators are used during periods of exacerbation. Then differences, when you are differentiating asthma and COPD, excellent differentiation, then I just wanted to add that one way of making the difference on spirometry, which should be one of the things we should mention, is that when you do the bronchodilator reversibility test, there's a bronchodilator reversibility test, although more recently in the new guideline for spirometry interpretation, you use bronchodilator responsiveness test. Okay, so for the bronchodilator reversibility, it's actually 12%, not 15. I think that 15% comes when you're doing a challenge test, methacholine challenge test. So it's 15%. So when you have a change in the FEV1, that's the 12% change between the post-bronchodilator FEV1 and the pre-bronchodilator FEV1. When you have 12% change or 200 mils change in the absolute value of the FEV1, then you're dealing more with asthma. In other words, what I'm trying to say that in asthma, you can have full reversibility, but in COPD, there's no full reversibility. So you don't have that 12% change. So that's one way to differentiate asthma and COPD, because asthma is the closest differential, just like you listed. That was very correct. Okay, and but also for the pathophysiology, you really mentioned it, that imbalance between the elastase and anti-elastase, very important part of the pathophysiology, because there's destruction of the connective tissue, that's the parenchyma, and one of the major components is the elastin. So there's destruction of that elastin by the elastase because of the imbalance between the anti-elastase and elastase. Okay, so for the treatment also, the use of the LABA and LAMA, just like you said, it depends on the stages, and the current stage classification now for management of stable COPD, you have the A, B, and E. So you could do that classification based on number of hospital admissions, then the MMRC scale of the patient, that's the Modified Medical Research Council Business scale, and the COPD assessment. I'll try and post all these things I'm saying on the chat, on the group. I'll post on the group. So that's, I think, to be clearer. So if the patient is in class A, you give the person just LABA. If it's a class B, you give LABA and LAMA together. And then if it's in class E, then you give, you can add ICS, just like you said, rightly said in COPD. Steroids, inhaled corticosteroid is not top on the management, so you can add the ICS if the person is in stage E. I'll post it on the group. And then if the patient is still not responding, then you can add roflumilast. Okay, I'll just post all these things on the group. And then for the if the patient comes in exacerbation, that's why you use your short-acting bronchodilators, antibiotics, mucolytics, oxygen, low flow oxygen. Okay, so those are my comments for now. Thank you so much.
Thank you, ma'am. Thank you. Really appreciate it.
Thank you, Chief Ekele, for that wonderful contribution. And thank you, Dr. Yahaya, once again for a wonderful presentation. There are some questions in the chat box. Thank you, Biamaka, for reposting, Chief. The question says, I think bronchogenic carcinoma should be up on the list of differential diagnosis because of the significant history of smoking. Then others are congratulating you and thanking you for an excellent presentation. So please, you can attend to that.
Yes, ma, I considered that. In my differentials, I mentioned it, but I think it should be a bit. But when I come to discuss the most important difference, that's why it's well highlighted. And maybe it should have been above the heart failure. But when I come to select the most important four, you can see it's number 3 as my differentials. Thank you, well noted. Maybe I'll update it and put it above the heart failure. Thank you very much.
Okay, I can see some hands up. Chief Faye, one of our latest fellows, please, you can ask your question.
Thank you very much, Dr. Yahaya, for this presentation. Also, I think part of the use of domiciliary oxygen is the duration, I think, is between 15 hours to 19 hours. And also that parameters of oxygen, value partial pressure of oxygen with core pulmonary, and also with polycythemia, it's also an indication. If there is polycythemia and that values of partial pressure of oxygen is also an indication of use of domiciliary oxygen. And as the first contributor said, that even in this, without exacerbation, they may need long-term treatment using controllers as needed. So the treatment for asthma is closely related to, almost similar to the treatment for COPD is almost similar to treatment of asthma, but with some differences. Thank you very much. It's a very nice presentation.
Thank you, sir. Thank you.
Thank you, sir.
Yeah.
Doctor.
Good morning. Okay. Good morning to our teachers and good morning, everyone. Well, I must join others to say you've done a very good job, and that was very commendable. Then thank you, Dr. Ikele, for making my job easy. You really said a lot. I'll just say one or two things. Can I be heard, please?
Yes, ma'am.
Okay. Well, just like someone said some days ago, when it comes to pathophysiology of any disease, I think it's always good to just note what are the key points. I mean, for the exam now. Because after I finished speaking, they were asking, are you a pulmonologist? Please don't confuse us here. What are the key points? 1, 2, 3, 4, 5, 6, we want to know in the pathophysiology. No, number one, you mentioned the exposure to noxious substance. So among everything, it's better to just note why saying those things. Let the key thing you want them to know come up. You know, the bronchial epithelial damage, that's also very important, which the noxious substance, is going to bring about. And then other thing that is also very key, when we are talking about COPD, we talk about two basic components, chronic bronchitis, the emphysematous changes. Of course, we know there are some other phenotypes, but those are like the key basic components. So you must be able to itemize what is the process that leads to the chronic bronchitis. Of course, we know from the epithelial damage, there's going to be airway inflammation. So you must be able to itemize that, okay, that will give the chronic bronchitis, there will be increased mucus production and the likes. So then the inflammation is both airway and systemic. So those are the key things that must come up. And then there's also some form of stimulation of fibrogenic process that occurs in COPD as against in asthma, which is what also contributes to the airway, the irreversible airway airflow limitation that they have. And another key thing that must also come up is the imbalance between the protease and the antiprotease that you rightly pointed out, which is called the loss of elastic recoil that they have, given rise to the emphysema. So those things should come up, and along the line, I'm able to tell them this will cause this, the chronic bronchitis, and this will also likely lead to the emphysematous change that they can have. Then for the maneuver, now I think I was on question 3. I must confess that at first instinct, I was giving them the diagnostic criteria. They said, please stop at those maneuvers. And that was why I had to stop and have a rethink. So what they wanted to hear at that point are the maneuvers that we usually do. And they are it's not something that we know. So for maneuvers for spirometry, you ask your patients to breathe in deeply to fill their lungs. You are trying to get get them to have total lung capacity. And afterwards, say they breathe out fast as possible to have a blast. So you want to know, you are going to do the FEV1 and then you are going to do the FVC. So those are calculated, but they were asking me what you have told us, their ratios now, they maneuver. So what they want to hear is you are going to ask patients to breathe out as fast as possible to blast out for you to get your FEV1, and then without taking a break in between, they continue to breathe so that you can get your FVC, and from there you can calculate the ratio. So you want to know how you are going to do your FEV1 and how you are going to get patients to do the FVC. So those were the maneuvers they really wanted to hear. I think you also mentioned pulmonary rehabilitation, that for those in stage 4, for COPD, pulmonary rehabilitation can come in at any point, not just for stage 4. I think the last thing that I will say was in the diagnosis. Dr. Ekele mentioned 12%, 15% too for asthma. They say it's of greater level of evidence, although we say more than 12%, and not all, it's more than 12% and 200 mils. So then more than 15% and 400 mils of greater level of evidence when it comes to diagnosing asthma. So once again, thank you for your wonderful presentation.
Thank you, ma. The corrections are noted, ma. Thank you.
Thank you, Ma, for the additions. We appreciate. There's another comment in the chat box. Dr. Faponda, she added more tips to help remember the pathogenesis of COPD. So she said inhalational oxidative stress, interplay between genetic predisposition, environmental exposure to noxious gases or dust that occur over a period of time. So you can use Get2 Mix to remember this. Thank you so much, Chief, for this contribution. Any more comments or questions for the presenter, or we move on to the next topic, question for the day?
Let's move on. Let's move on. Thank you so much, Dr. Adai. You did so well. Nobody will have thought that you were having your initial, you had inertia. Thank you so much. So you are a natural. Thank you. Dr.
Thank
Dr.
you,
Chris
ma'am.
Abed.
Yes, Dr.
Please, I
Kayode.
don't know if I can just say one or two things, though most of the thing has been said. Can I
Okay.
just few minutes?
Go
Okay.
ahead, please.
Thank you, Dr. Yaya. Good morning, everybody, senior colleagues and colleagues. Just to add one or two things, most of the things has been said. We have a lot of pulmonology in the house. Thanks, all of you. Just advice, like Dr. Yaya, to start with, during the course of presentation, it's a general advice for everybody. After you have answered the question and you are presenting, it's usually good to link your presentation with the index case, most especially the features that are actually present. And that will go a long way for individual, anybody, to link your diagnosis or differential, as the case may be. Then the second thing, I think Dr. Fihi had sorted out that one. Since the spirometry is effort dependent, the maneuver is mainly the forceful blast. The two parameters that are actually needed has been explained. Well done to Dr. Yaya too. Then the other thing I want to say, in your differential, the first differential, just like what we were saying, there is always good to go straight to the point. You mentioned asthma. And just to tell everybody, because sometimes you may have some toxic examiner, they want to ask you, especially on like a national, the West Africa, it can be in that station, it may not be a pulmonologist. If you say asthma, they may ask you, is it cardiac asthma? They may even want to waste your time. Cardiac asthma, or is it the occupational asthma or breathing asthma? It's always good to be specific. Bronchial asthma, and you move. We all know that when we say asthma, it's usually referred to bronchial. But some toxic examiner may want to waste your time. I am a product, I've witnessed this one time without number. Please, let's take note. Then the other thing I need to mention briefly, in your differential, you mentioned bronchiectasis, and you mentioned it early enough, maybe number 2 or so. They've already said in the questions that the features were, I think, bronchiectasis and fibrosis were ruled out. So they already know. So if that should come in, it should be down the list so as to get as much as many marks as possible. You can mention other which they've mentioned, most especially bronchogenic carcinoma, lung cancer, which somebody mentioned now because of the pack here, among others. And in this kind of thing, the respiratory differential should be explored before the other though COPD is more of systemic, respiratory and systemic, as we alluded to. The other respiratory differential should also be as much as possible, except when you have exhausted that and it's not coming. For example, PTB could come in, the interstitial lung disease could come in. Even sometimes, then the occupational lung disease, pneumoconiosis, is also good to be specific if you have idea of any, except if you don't. Then even community-acquired pneumonia, though the duration is like 3 months, but it can still come in before we now consider other non-respiratory like heart failure, among others. But take note, bronchiectasis should come down the list, even fibrosis, if it must come. Then the rounding off, you mentioned in the course of presentation, clubbing are usually not seen COPD. Yes, it is true. Even PTB, straightforward. But when you see them, you think of further complications. Complications like suppurative lung disease in them, or even bronchogenic carcinoma. It can actually happen, but it's not a straightforward stuff. Lastly, oxygen. I think you mentioned it other non-pharmacological. I think it should come under pharmacological because we prescribe oxygen. I think it should come under. By and large, it's actually a lucid presentations. Thanks and God bless. Thank you.
Thank you, Dr. Kayode. Thank you. It's always a pleasure hearing your voice. Now you have a lot of children, so thank you. I appreciate you. Dr. Yaya, once again, join others to say thank you and well done. You're already speaking like a fellow. Thank you so much. It was quite detailed. Presentation was quite detailed, clear. Thank you so much. From all the comment and interaction, you know that you did a good job. If you didn't do so well, there won't be so much. You won't have arrived so much discussion. So thank you once again, Dr. Ada, our dear podding pulmonologist. Today seems to be the day for the pulmonologist. Thank you so much for anchoring. Dr. Adewale, you have the floor. Dr. Yaya, you can continue.
Okay, ma. Now we are going for the last question from this West African recall practice questions. So
Yes,
Dr.
I know.
Adewale is going to present question number 4B. I think ma, he can go ahead, right?
Please let him go ahead, please.
Okay, go ahead, Dr. Adewale.
Good morning, everyone. Permitting me to stand on the existing protocol. I'll be presenting practice question 4B of the recently concluded West Africa College of Physicians March 2024 exams. So the question states, a 20-year-old nurse intern had malaria and fever for more than a week, which she attributed to work stress. She took anti-malarials, but there was no relief. And a matron told her to take antibiotics as well. When her symptoms persisted, she came to see you. At this time, she had developed sore throat, rash, and tingling sensation in the ears. The first question is to list 6 additional questions you would like to ask her. So the first thing that comes to mind is additional symptoms to support my suspected diagnosis or differentials. So which would include history of conjunctivitis, if there's history of vomiting, particularly if it's repeated, if there's facial swelling, non-dependent edema, pain in the chest or back, and abdominal pain. Another important symptoms that is worthy of mentioning apart from the ones I've just mentioned is history of bleeding from any of the mucous membranes or orifices, including the gum, the eyes, the nose, GI bleed as well. I also like to ask if there is any history of contact with a patient with similar symptoms due to the patient's occupation being a nurse. History of contact with rodents or droppings, as we live in an endemic area where we have proliferation of rodents that I suspect may be the cause of this patient's problem. Also, history of recent ingestion of rodents or rats, I think is also important. And then occasionally when we have outbreak is endemic disease in our locality, it usually affects some states. And for 2014, this appears to be the high-risk states in the country, namely Ondo, Edo, Bauchi, or Benue states. So question 2 states that list 4 differentials. So my first differential is Lassa fever. And this is due to the quite non-specific symptoms that the patient has mentioned, malaria, fever, and the fact that the patient has taken an anti-malaria with no relief, as well as antibiotics, and then the fact that the patient develops sore throat, rash, and particularly tingling sensation in the ears. Second differential is viral upper respiratory tract infection. Like I said, most of those symptoms are non-specific and could be seen in viral respiratory upper respiratory tract infection, which can be due to adeno or rhinovirus, or even the COVID-19 virus as well, could give a similar presentation. Poorly treated malaria, yes, it was stated that patient had taken anti-malarials. What anti-malaria, what dose, for how long was not stated. So that's also a possibility. Enteric fever as well, which is most of the time a clinical diagnosis, but I think would have other features such as abdominal pain. Then the classic triad will be headache, fever, and abdominal pain, plus or minus vomiting, diarrhea, and the rest. Streptococcal pharyngitis, because patients with Lassa fever sometimes present with pharyngitis, which can sometimes be exudative. And this can be similar to presentation of streptococcal pharyngitis. What is the most likely diagnosis? That's Lassa fever caused by the Lassa virus. What is the vector? Multimammate rat is the vector. Mode of transmission, this would include ingestion of contaminated food by the droppings of the rats vis-a-vis either feces or urine, or sometimes inhalation of the virus from the droppings of the rats, also said to be a form of transmission. Also, ingestion of the infected rodents as food source, because it's been said that with the infected rodents, they can continue to shed the virus through their lifetime. Person-to-person transmission is also possible, as well as nosocomial within the healthcare system. And this is when the individual is exposed to the virus in the blood tissue secretions or excretions of an infected individual. What investigations will I want to do? Okay, so reverse transcripted polymerase chain reaction, PCR, can be done to identify the virus, as well as enzyme-linked immunosorbent assay, which is commonly done for which detects either IgM or IgG, as well as antigen of the Lassa virus. Other investigations will be ancillary investigations, but care should be taken, especially in sending samples to laboratories which cannot handle the organism due to the high rate of infectivity. So the other investigations will include the full blood count, electrolyte and creatinine, liver function tests, urinalysis, and the rest. How will I manage? I would like to give intravenous ribavirin. It's said to be more effective when given earlier in the course of the disease. There are 3 different regimens which can be given. I would like to admit the patient to an isolation ward, and then supportive care, which would include fluid and electrolyte balance, as well as maintenance of patient's blood pressure. Pain relief as required, supplemental oxygen indicated, blood transfusion if indicated, antibiotics if there's evidence of coexisting or spine post-bacterial infection, ICU care if patient sensorium deteriorates, so there's need for more critical care and monitoring. Renal replacement therapy if patients develop acute kidney injury, which is one of the complications of the infection, and then nutritional support. So this is just a table showing the regimens. I believe we've gone through this recently. And then list 4 complications that can arise from the disease. So we can have sensorineural deafness of varying degrees that has nothing to do with the severity of the illness. Can have encephalopathy, example encephalitis, which is also a poor prognostic factor in patients with this disease condition. Pregnancy loss, thrombocytopenia, can have shock from sepsis, as well as hypovolemia or hemorrhagic shock. What is the prognosis? Mortality rates for all cases from mild to severe is about 1%, 15% in hospitalized individuals, and it's said to be higher sometimes when there's outbreaks, and it can be as high as 33% in pregnant women. And these are some of the factors that are associated with poor prognosis. When you have high viremia, if you have serum, AST greater than 150 international units per liter, bleeding, encephalitis, edema, 3rd trimester of pregnancy. This is the end of my presentation. Thank you. Dr. I think recently made a presentation on Lassa fever, an update on Lassa fever that is quite detailed. And some of these slides are from his presentation. Thank you.
Thank you, Dr. Adewale, for this excellent presentation. Thank you very much. We can entertain some comment additions from our colleagues and senior colleagues and our teachers. Thank you, well done. Any comment, please? For our seniors that participated in the exam, any additions from what has been presented or something like that?
Dr. Tanimu and Ekele are raising their hands.
Okay, go ahead, sir.
Thank you very much, Dr. Adewale, for this nice presentation. Can you go to investigations? Can you go to investigations in your slides? Okay. After you have to list as important investigations first. The important investigation looking for the likely complications. And these ones include clotting profiles, prothrombin PT and PTTK, full blood count, and serum UNE. When you are mentioning investigation, you mention them according to importance. After the diagnosis, which is PCR, and you can use a laser, when then you say the important investigations like serum UNE because of nephropathy, clotting profile because of bleeding diathesis, and you go along those investigations. You can, so that is it in the investigation. And also for the differential, you can list important differentials. Since this one is part of the viral hemorrhagic fever, you can part of your differential can be dengue fever. And closer ones, community acquired pneumonia because of the location, all those ones. So you can, but by and large, it's a very nice presentation. Keep it up. We are all learning. I'm very happy to be in this group because I have learned a lot, and also I gain a lot. Thank you very much.
Thank you, sir, for this addition. Thank you. We appreciate. And please, I can't see anybody raising hand. If there is anybody, can speak, please.
Okay. Good morning, my teachers and colleagues. Thank you so much for the excellent presentation. Mine is a question. I just wanted to ask, just the way they said, if you're asked about the pathophysiology of any condition, you should just go straight to the point. I don't know if you can just help us, like, in case you're asked what's pathophysiology, like keywords, that you can say. I don't know if you came across that. Thank you so much.
Okay, so yeah, I did come across that while I was reading, although I didn't pay so much attention to it. So part of it was epithelial dysfunction from the virus leading to, which is responsible for the bleeding in the mucosal tissue, as well as dysregulation of the clotting system, including thrombocytopenia, which can contribute to the bleeding that they present with.
Okay, thank you.
Thank you.
Yeah.
Anybody raising hand? Because I cannot see, can speak, please. But so far, there is nothing much from the chat box. Okay, Dr. Olalekan is saying, thank you for the excellent presentation. The question on what is the mode of transmission, which one of the three listed modes of transmission should one mention? So he's asking a question on the mode of transmission. He said, which one of the three listed modes of transmission should one mention? I don't know. Is it if you are asked only what is the main mode of transmission? And then Dr. Kaide is also saying COVID-19 may still be considered as differentials in this index patient. So those are the comments actually. Yeah.
All right. Thank you very much, Dr. Yaya. Thank you everyone for the questions. I'd like to start with one of the differentials that Dr. Tanimu mentioned. So one, there is no history to suggest bleeding. We are not sure what the rash is in this individual, which is why I didn't mention other viral hemorrhagic fevers. Because patients with Lassa can have a maculopapular rash, not necessarily due to bleeding into the skin, which can also be described as a rash. Then also community-acquired pneumonia being a differential here, I would maybe put that very, very low down because we don't have the classic triad of fever, tachypnea, and cough as presenting complaints, which is what you would expect from a patient with pneumonia. And I did also mention, thank you, Dr. Kayode, for that addition. I did mention as part of the viral respiratory tract infection that COVID-19 disease can also present this way. And then for the last question about which is the most important, I came across rodent to human transmission. So that's via contact or either inhalation or ingestion of contaminated food materials with droppings from the rodents. That's the primary mode of transmission. Or yeah, that's the primary mode of transmission. Thank you.
Okay, thank you very much, Dr. Adewale. I think it's high time to hand over to Chief Dr. Christabel. Well done, ma'am.
Well done, Dr. Yahaya. Dr. Adewale, thank you. There's something you did that was quite commendable. You acknowledge